Hi, this is the second lecture in the foot and ankle part of the orthopedic board series. In this lecture, we're going to speak about insertional Achilles tendinopathy. A good source that you can use is this book written by myself. So first, let's speak about the anatomy of the Achilles tendon. So the Achilles tendon is actually the aponeurosis of two muscles, the gastrocnemius muscle and the soleus muscle. As we all know, the soleus is more deep than the gastrocnemius muscle, and then the tendon is formed by the aponeurosis of these two tendons. The tendon will do a 90-degree curve before its insertion, and this will bring the more superficial or the more posterior muscle, the gastrocnemius, more posterolateral, and the soleus muscle, which is anterior, it will come into more of an anteromedial, as you can see here in this picture. So this picture here is from the posterolateral. You can see here the part from the gastrocnemius is forming most of the posterolateral insertion, and the soleus muscle, it will also turn 90 degree and it will come more into the anteromedial part of the insertion. So the Achilles tendon is a conjoined part of the gastrocnemius and soleus aponeurosis. Before its insertion, it has a 90-degree curve which will bring the gastrocnemius, the more posterior or the more superficial, into the posterolateral part, and will bring the soleus, the more anterior or the more deep, into the anteromedial part. The Achilles tendon is composed mainly of type 1 collagen, and it has a paratenon, so it does not have a true sheath. It has a paratenon, and it's composed mainly of type 1 collagen. The Achilles tendon insert about 2 centimeter distal to the posterosuperior part of the calcaneus. So the Achilles tendon does not insert here, it's actually insert about 2 centimeter distal to here, and that anteroposterior part is about 5 to 6 millimeter. So Achilles tendon, it's a type 1 collagen mainly. It's surrounded by paratenon, not by a true sheath. And it does not insert here in the posterosuperior calcaneal tuberosity. It inserts distal to that, about 2 centimeter distal to that, with an anteroposterior area of about 5 to 6 millimeter. 2 to 6 centimeter from the insertion, which is this area. This is an area of hypovascularity of the tendon, or what we call vascular watershed area of the tendon. So insertional Achilles tendinopathy occurs at the insertion of the tendon. So as we're going to see in the clinical picture, the swelling and pain is at the distal part of the tendon, insertional. That's why it's called insertional Achilles tendinopathy. What are the risk factors for the Achilles tendinopathy? Quinolones antibiotic like the ciprofloxacin and the levofloxacin, diabetes, obesity, steroids, hormone replacement, oral contraceptive, all these are risk factors for Achilles tendinopathy. If you examine the tendon under the microscope, it will be loss of the parallel collagen structures, so the collagen fibers will not be parallel. There will be fatty infiltration and capillary proliferation. There will be absence of acute and chronic inflammatory cells, so it's not tendinitis. So that's why it's called tendinopathy. It's more of a degeneration, and as we said, there is loss of the collagen, parallel collagen structure. As we said, the healthy Achilles tendon is mainly type 1. In Achilles tendinopathy, there will be increased type 2 and type 3 collagen with decreased level of type 1, and the tendon thickness will increase. So in ultrasound or MRI, if you have more than 6 millimeter thickness, that's an indication of insertional Achilles tendinopathy. Let's talk about the clinical presentation of insertional Achilles tendinopathy. There will be pain. This pain increases with activity. Also, there will be stiffness after periods of rest. When you examine the patient, there will be swelling and redness at the back of the heel, and there will be tenderness to palpation in the most distal part of the Achilles tendon, because this is insertional tendinosis. And then when you assess the range of motion, you will find that the ankle dorsiflexion is limited in most time. You can do the silver scoid test to assess the isolated gastrocnemius. and you will find a plantar flexor weakness. So again, there will be pain at the heel. Patient will complain of pain and also will complain of some stiffness. Examination will show swelling, redness, and tenderness to palpation in the most distal 2 centimeter of the Achilles tendon. The range of motion will show limited dorsiflexion, and there will be plantar flexor weakness. Regarding imaging in insertional Achilles tendinopathy, the lateral X-ray of the ankle can show if there is enthesophyte, which is calcification of the insertion of the Achilles tendon. There will also can show intra-tendinous calcification, and it can show the Haglund deformity. As we said before, also the magnetic resonance imaging, the MRI, can show the degeneration of the tendon and can tell you the percentage of the affection of the tendon. And also we mentioned before that ultrasound can detect the degeneration. And we mentioned if you have more than 6 millimeter thickness of the tendon, this is a characteristic of insertional tendinopathy. So X-ray can, as we said, it can show if there is enthesophyte, which is calcification of the insertion of the tendon, intratendinous calcification. It can show the Haglund deformity, which is increase in the size of the posterior superior calcaneal tuberosity. MRI and ultrasound can show the degeneration, and it also can show the thickness of the tendon. We have to remember that sometimes there is imaging signs of tendinopathy in the MRI or the ultrasound, even in the X-ray. However, if there is no clinical signs of insertional tendinopathy, this should not be considered a case of insertional tendinopathy. So if you have imaging signs of tendinopathy, whether in X-ray or ultrasound or MRI, but the patient is not complaining, or the complaint of patient is not related to the posterior ankle, the most distal part, this is not an insertional tendinopathy, because the case requires a full picture of clinical examination, as we showed before, together with the imaging studies. Regarding the treatment for insertional tendinopathy, the non-operative treatment is the main treatment of this condition. Insertional Achilles tendinopathy is extremely common condition. Most of the cases can be treated non-operative. The main non-operative treatment is strengthening exercises, as we're going to see in the next slide. Also, one of the main methods is heel lift to relax the tendon. Other methods that can be used is the ISWL, extracorporeal shockwave therapy, night splints, and injections. Eccentric exercises is the main line of treatment, as we said, and this is what you're going to put in the therapy prescription. So when you send these patients for therapy, this is what you have to put in your prescription so that the therapist can work on that. Eccentric exercises basically mean stretching and strengthening. So it is controlled loading of the tendon while stretching the tendon. So eccentric exercises is the main line of treatment in the therapy. And to be noted here is both insertional, which happens in the most distal part, and non-insertional, which happens about 3 to 4 centimeters from the insertion. The main treatment is eccentric strengthening exercises. So eccentric exercises, this is commonly comes in the exam. This is what you want your patient to do in the therapy prescription. So it's eccentric exercises, which means strengthening while lengthening the tendon. So it is controlled loading of the tendon to strengthen the tendon while stretching it. The ISWL, or the extracorporeal shock wave therapy, it can reduces the pain. However, there is no standardized protocol for the insertional tendinopathy, and the treatment itself can causes pain during treatment, and it may take a little bit time for the patient to feel better. And effectiveness is not in every patient. It may be limited to patient who has marked enthesophytes. which is the calcification of the insertion of the tendon. Regarding injection, in these cases, you should never inject steroids because it can cause weakness and rupture of the tendon. There are some studies with good effectiveness for PRP injection. Operative treatment is indicated in case the patient does not improve with non-operative treatment. The main operative treatment is open debridement of the tendon with removal, possible excision of the Haglund exostosis or what we call calcaneal ostectomy or exostectomy. So the main treatment is open debridement of the tendon with possible calcaneal ostectomy, which is removal of the Haglund exostosis. Some cases will require flexor hallucis longus FHL transfer, and this is mainly in cases in which debridement involves more than 50%. However, recently more and more cases are done only with open debridement of the tendon, full detachment of the tendon from the bone, and then reinsertion of the bone using a bone anchor. If there is a contracture of the gastrocnemius, you can always add gastrocnemius recession to the procedure. As we said, open debridement is the main treatment with decompression of the tendon by removing the Haglund bone. Doing the calcaneal ostectomy is the main line of treatment. As you can see here, most surgeons now use midline incision to approach the tendon with minimal subcutaneous dissection, so you can go directly to the paratenon and split the tendon, open the tendon, in most cases detach the tendon from the bone, remove the calcification and the degenerated part, and then at the end repair the upper part of the tendon, and the lower part of the tendon can be put back in position using anchors. This is from the website of Arthuric's company, using something called the speed bridge. It's a knotless system, and more surgeons are using this system now. So again, most surgeons will go midline, minimal dissection, split the tendon, and peel the tendon out of the bone, and then remove the degenerated part from inside, the calcification, and then also remove the Haglund deformity, and then repair the upper part of the tendon and resuture the tendon to the bone using anchors. Here, this is one of my patients. You can see here the calcification. Here's the Haglund deformity, and then this is after surgery. This was we did midline incision. We removed the calcified part, and we removed, as you can see here, the difference between this part and this part. We removed the Haglund deformity. You don't have to remove too much bone, only a few millimeters is more than enough. And then the tendon after that was repaired and put back into the calcaneus using bone anchors. As I said, most surgeons now, in most cases, don't use FHL. There are some advantage of the FHL transfer, as we're going to see in the following slide. In the surgery of open debridement, you can detach up to about 50% of the insertion of the Achilles into the calcaneus without having to augment. However, if you have to do more than 50% detachment, you will have to either put the tendon back in position, as we said, using anchors, or you can do the FHL transfer. So in most cases now, people will detach the tendon completely, debride, and then put the tendon back in position in the calcaneus using the anchor. As we said, if you do more than 50% debridement, you can add the flexor hallucis or FHL transfer. This surgery, the debridement surgery, especially in elderly, can take a long time before the patient feels better. So there were some studies that the surgery can take up to 1 year for an elderly patient for them to regain the ankle function. So in the open debridement, you can release up to 50% without having to augment. If you release more than 50%, you have to put the tendon back in the bone using anchor. We said in the previous slide that this is a picture from Arthuric's website. It's one company that used what's called the speed bridge. It's knotless anchors that in 2 rows put the tendon back in position. Also, if you end removing more than 50% of the insertion or debriding more than 50%, you can add the flexor hallucis FHL to your debridement. And as we said, the surgery, especially in elderly, take a long time to regain the ankle motion. FHL transfer, adding the FHL transfer, I'd like to give some points about it. As we said, if you end the breathing more than 50%, you can consider FHL transfer. Adding the FHL transfer to the debridement mainly help with the plantar flexion strength. This is the main advantage of adding the FHL transfer. Studies shows that whether or not you add the FHL, the result is equal regarding clinical outcome, satisfaction, pain score, and even the big toe plantar flexion strength. The main value, as we said in the FHL transfer, is you will have more power in plantar flexion. That's why recently there are more and more surgeons, especially in elderly patients, do not do FHL transfer. They just put the Achilles tendon muscle back into position using anchor without doing the FHL transfer. Adding the FHL transfer, as I said, mainly plays some role in mild increase in the plantar flexion strength compared with not doing the transfer. Whether or not you do the transfer gives equal clinical outcome, satisfaction, pain scores, and big toe plantar flexion strength. For the isolated gastrocnemius recession for the condition of the insertional Achilles tendinitis, the evidence is conflicting. If you, by examination, find the gastrocnemius muscle is tight, you can always add that. However, as we said, using this surgery in the insertional tendinitis have conflicting data in the literature. I'd like to thank you for listening to this lecture, and hopefully this lecture and other lectures will help you in your final exam.